Welcome to the members of the Kentucky Commission on Women who are with us today by Zoom, and to anyone else who might be watching this live or archived stream on YouTube. My name is Heather Deering, and I am the Deputy Chief of Staff to Lieutenant Governor Coleman and staff to the Kentucky Commission on Women. I'm so pleased to be here today for this installment of our virtual Conversations with Commissioners series. The Kentucky Commission on Women was established in 1968 by Governor Louis Nunn by executive order, and then became an official state agency in 1970 through legislative action. After a period of dormancy, the commission was reactivated by Governor Beshear when he charged Lieutenant Governor Coleman with revitalizing it. Over the past several years, we've reestablished ourselves as the state agency whose mission is to strengthen, empower, and elevate women and girls in Kentucky. Our commissioners are an incredible, diverse group of women from all corners of the Commonwealth, and we are so lucky that they are serving in this role. When we launched our virtual Conversations with Commissioners series, a live stream virtual conversation between commissioners and guests about a topic or theme we feel is important to women in the Commonwealth, it was our intent to share these important conversations with the entire state. We invite special guests who are knowledgeable or experts in their fields to present information, and when we have time, open it up for questions from commissioners. Our theme, our guests, and our commissioner host changes every conversation. As you likely already know, our topic today is Kentucky Women's Health. Last month was Women's Health Awareness Month, and during that month, the Commission started the process of researching and gathering data about women's health in Kentucky. And even though it's no longer May, we felt it was still important to have this critical conversation. So now I would like to hand it over to our conversation host today, the chair of the Kentucky Commission on Women, Lucy Gentry.
Thank you, Heather. My name is Lucy Gentry, and I'm the chair of the Kentucky Commission on Women. I'm so excited to be here today to talk about the status of Kentucky women's health for a lot of reasons, but especially because of my professional connection to mental health. I have a master's degree in social work from the University of Kentucky, and I'm a licensed clinical social worker. I've spent over 20 years in the field of psychiatric care, so it's something I'm very passionate about. One thing I know because of the work I do every day at the Ridge in Lexington is that when we talk about health in general, we're also talking about, or we need to be talking about, mental health as well, and trying to reduce that stigma and give more awareness to it. So last year, the Commission published a Status of Kentucky Women report that highlighted some basic statistics and data about women and young girls in our Commonwealth. So I want to share some of those with you right now. 31% of 10th grade, so this is sophomore girls in high school, in Kentucky reported serious psychological distress. 2 years ago, 21% of Kentucky women ages 18 to 44 reported that their mental health was not good. But since then, that number has increased to 25%. So that's 1/4 of our Kentucky women. I mentioned those facts so we can keep them in mind as we have our conversations today. We know that mental health and physical health can affect each other. Research shows that people with a mental health problem are more likely to have a preventable physical health condition, such as heart disease, which is the #1 cause of death for women in Kentucky. And hopefully we can touch on that later. We have a lot of information for everyone. This conversation is so important today. I'm thrilled to have our amazing guests. So we're lucky today to have Dr. Connie White, who is the Deputy Commissioner of the Kentucky Department for Public Health. And we have Dr. Stephanie Rose. She's the Director of the Division of Women's Health in the Department of Public Health. So these two experts, between both of them, they have so much experience and knowledge about maternal health that we'll get into, and women's health that just overall that I want to get right into. So Dr. White and Dr. Rose, if you could please introduce yourselves.
Hi, thank you so much, Lucy. I'm Connie White. I'm the Deputy Commissioner for Clinical Affairs at the Kentucky Department for Public Health. I have been in this role since December of 2012. I did come to the department in 2009. I was actually in Dr. Rose's position. I was brought into public health as the Division Director of Women's Health. Before that, I had 20 years of OBGYN experience here in Frankfort, Kentucky in private practice. I run into people that were former patients, and I run into people who I have delivered some 20, 30 years ago. It's a special place to work, and we do wonderful work with a great team. So I'm very excited to be able to share some of this information with your audience.
My name is Stephanie Rose. I am really grateful to be here today. And before I talk about myself, I do want to thank my team in the Division of Women's Health, who do incredible work to promote access to care for all women in Kentucky. And I also want to send a special shout out to my student intern, Anna Gummery, who did so much work on getting me a lot of information for our talk today. So before I came to the Division of Women's Health, the Kentucky Department for Public Health, I also work at the University of Kentucky. So I attended medical school at the University of Louisville, and then I completed my residency at UAB, University of Alabama at Birmingham, and then I did a general medicine fellowship at Mass General Hospital and a Master's of Public Health at the Harvard School of Public Health. Currently, I get to split my time between these two jobs that I really love. So I work in internal medicine here at UK, and I see patients in general outpatient internal medicine, and also work with residents and med students. And I also have been certified in obesity medicine since 2013, and I run a weight management clinic as well. But I came to the Division of Women's Health in 2022. And when I first came to UK, I was using my Master's of Public Health more in clinical research setting. And so, coming here has really given me the opportunity to use my Master's in Public Health in a different way, learning how the government works and, see what people are doing in the field, in the trenches, as you might say, and just all the incredible hard work and intelligent people who work here. It's really been eye-opening, and I've really enjoyed it. So thank you so much.
Thank you. Thank you both. Okay, we're going to get right into the questions. So, Dr. White, I want to start with you. It's a two-part question, pretty big question. The first one I'm going to ask you. What is the overall status of women's health in Kentucky, and how does the Kentucky Department for Public Health address women's health broadly?
Okay. I think what I'd like to start with, and I know many of you have been in meetings where you've done mission and vision statements, and why are we doing this? And it takes a lot of time. But if you really get a good vision statement, it sets the plate, puts the plate on the table for everything you do. And our cabinet vision statement is that every Kentuckian reaches full human potential and all communities thrive. It doesn't say we're going to make everything perfect for everybody in every place, but it's telling us that we want to try to get people to the best place they can be, meet them where they are, and get them to a place that's the best that they can reach. So with women's health in Kentucky, we have some successes that we're going to talk about today, some things that I'm particularly proud of, especially in my long tenure here at the Department for Public Health. We have very good health insurance coverage. That is something that I'm extremely proud of. We have 93% of reproductive age women, 16 to 14, have health insurance. Well, so what's up? That means 7% of them don't. But if you look at where we were in 2013 before we expanded Medicaid, that rate was 77%. So 23% of women in reproductive age group did not have health insurance at that time. And right now, Texas has a 23% rate of uninsured. So I think our 7%, we'll talk a little bit later about why we think that is. Kentucky has set the table at Medicaid for expansion. Not only did we expand Medicaid in 2014 when the Affordable Care Act was expanded, but in 2022 we expanded postpartum care or care for women after delivery for up to 1 year. And that's really important because when I was in practice, you had a baby. I had 6 weeks that I tried to get you that cardiology appointment and get you to see the dentist and get you all of those things I was trying to get because I knew your insurance was going to run out in 6 weeks. With this new provision by Medicaid, you've got a whole year, which is important because almost half of our maternal deaths happen in that time after delivery. So we need those women to have that coverage for that full year. We have presumptive eligibility, which a lot of states don't have. That means if you come to my office and you're pregnant, we can get your paperwork and you can be covered that day. You don't have days that you visited the doctor that you're going to have to pay out of pocket. Pregnancy is now a qualifying event in Kentucky, which means you don't have to wait for open enrollment. If you are pregnant, that's a qualified event that you can now get maternity benefits. We cover everything for pregnant women that we cover for anyone else. And a lot of states only cover certain things for pregnant women. We have adult, whether you're pregnant or not, we have adult access to dental care and to eye care. So people can not just get their teeth pulled, but they can get dental care and they can get glasses. This is huge for people trying to be employed. If they have teeth pain, if they have bad teeth, if they can't see, these are truly economic development issues. And we were one of the first states to cover every single smoking cessation medication that's available out there. Every MCO has to cover everything. Our efforts to try to decrease our tobacco use in Kentucky is huge when you look at our overall health outcomes. Our burden of disease, for a lot of complex reasons, we have a lot of obesity in Kentucky, which means we have a lot of heart disease in Kentucky, which means we have a lot of diabetes in Kentucky. And those numbers are sky high. I'm not going to give you a bunch of numbers today unless somebody asks or wants those, but I can say that we're in the top. We're fourth highest for diabetes mortality in Kentucky. We have a lot of work to do. We are improving. I will say that. It's just that the rest of the nation is improving also. So as we're going up, they're improving as well. But over a third of Kentuckians are obese, not just overweight, but obese. And the harms that can cause to the kidneys, coronary arteries, that cascade event will lead to a lot of bad care or bad health outcomes for us. And we have high rates of cancer in Kentucky. We are the #1 state in the nation for cancer. And that's largely because of our high rate of lung cancer. I wasn't able to tease out lung cancer for women versus men. I do know, though, that for lung cancer, we are 46th in the nation for lung cancer, and we are 49th in the nation for smoking. I'm sorry. We are 46th in the nation for smoking in the U.S., not lung cancer. 46th for smoking and 49th for smoking during pregnancy. So a lot of behavioral decisions that need to be made, but people only know what they know. And our job is to not shake our finger at them and tell them, you shouldn't do that. Our job is to be sure we inform people so they can make a real informed decision. But if they look around them and they only know one thing, that everybody they know smokes, or everybody they know lose their teeth by the time they're 18. It's very difficult to get people to change their behavioral patterns if they don't have a health reality that's on a positive trajectory. We have substance use disorder, and we'll talk about that in pregnancy, but we will say that Kentucky this year was the 3rd year in a row that we have had a decrease in overdose deaths. Most of them were from fentanyl. We had a 30.2% decrease. We also had a decrease in our Black Kentuckians that had overdose deaths. So we're pleased with that work, but there's lots of work to do. Find naloxone, ky.gov. You can get on there and get free naloxone. I can't tell anybody I was on this call because Chris Smith will mention that website. But it is a way that people can get free naloxone to reverse an overdose. We're 49th in the country for depression. We're 45th for frequent mental illness among adults. So we've got lots of work to do. 1 in 5 of our children are food insecure. And that's not a woman stat, but you've got 1 in 5 children that are food insecure. That is a burden for the mothers of those children. And that certainly colors the way they look at everything that they're doing. And probably the thing that pulls all this together more than anything, Lucy, is we are so high in the poverty world. If we in this group on this screen, live a very blessed life. But when I think back of some of the things I said to patients when I was in clinical practice, because I didn't know what I know now, and I'm lecturing some woman about she needs to be cutting her carbs because of her gestational diabetes and eating better. And now I know that she's just getting enough food to put on the table for her kids to eat, and whatever's left after they get it from the table, that's what she eats.
Mhm.
We have to know those situations. When I have a patient tell me my blood pressure is up because this isn't my month for my blood pressure medicine, because I take my heart medicine 1 month, my blood pressure medicine 1 month, and my diabetes medicine 1 month, because I can only afford one medicine a month.
Mhm.
Those are the kinds of things that we have to know if we're going to truly help people. I mean, we've got lots of successes. We've got less premature births. We've got less smoking in pregnancy. We've got more breastfeeding initiation, less preterm births. We're doing more hearing screenings in hospitals. We are making progress, but we have so much to make up for, and we're doing it in a milieu, in a world of poverty. So how can we take the programs we have now, especially since we may be losing some of them? How can we take the programs we have now and utilize them to the fullest for our fellow Kentuckians?
Thank you, Dr. White. Real quickly, I was going to ask this question later, but we're on the topic. And if you can just give us a brief summary. You talked about the 7% of women that don't have health insurance.
Yes.
So what do you think contributes to that? What's going on? What do we need to do for that 7%?
Well, when we look at households that don't have insurance, they're usually single mom households. Lots of women do not understand that they are they can get Medicaid. They have a language barrier, or they have health literacy issues and they just don't know they can qualify for Medicaid. Some of them make just enough money that they don't qualify for Medicaid, but they don't work in a job that offers health insurance. And so they can go on the market now to buy insurance, but even those low rates are sometimes too high to fit into their budget. And if we lose the marketplace, which is a possibility through the next federal budget, there really won't be an option for them. We've got people with no citizenship that don't qualify, so they can't get health insurance. People who live in rural areas don't have as much IT ability, so they can't go online and apply for different things. So it's a very complicated group of things that bring us that 70% of uninsured rates.
Thank you. Thanks, Dr. White. Dr. Rose, so can you tell us a little bit about what the Division of Women's Health is, and then how it serves Kentucky women? I think you're on mute.
Hear me now?
Yes, ma'am. I got you. Thank
Good.
you.
So the Division of Women's Health was actually created in 1998. And it is actually the only division that is mandated per legislation. But actually, two of the primary programs that we do have actually been around longer than there was actually a division. So the Division of Women's Health consists primarily of 3 programs and a couple other things as well. So the 3 programs are Kentucky Family Planning, Kentucky Women's Cancer Screening Program, and the Breast Cancer Trust Fund. We also maintain a Women's Health Resource Center, which focuses on targeted care and comprehensive health education specifically for women. And we're working on improving that as we go. And then our website, as Dr. White may have alluded to, also houses information on perinatal and maternal mental health. So let me talk briefly about our 2 primary grant programs, or our 3 really. So first of all, I want to talk about Kentucky Family Planning. That we have actually participated in that and this is a federal grant program, and we have actually participated in this federal grant program since Title X's inception in 1970. So this is when Congress enacted Title X of the Public Health Service Act. So Kentucky Family Planning's core services include contraception services, pregnancy testing and counseling, optimal family spacing assistance, basic infertility services, sexually transmitted infection services, preconception health, and basic preventive health services. Do be aware that, just want to make people aware that abortion has never been a part of any Title X funding of that federal grant program. The Kentucky Family Planning Services are provided both to females and males of any age, including adolescents, and are confidential. They're income-based, and clients at or below 100% of the federal poverty level are not charged for any KFP service. So then I want to talk about our next primary federal grant program, which is the Kentucky Women's Cancer Screening Program. And again, been around longer than actually our division has been around. So state legislation established the Kentucky Women's Cancer Screening Program back in 1990, and this was the same year that Congress passed the Breast and Cervical Cancer Mortality Prevention Act. So I'm really proud of the fact that Kentucky has been an early adopter of so many important programs, not only the Affordable Care Act and Medicaid expansion, but all these important programs for women as well. So the Breast and Cervical Cancer Mortality Prevention Act directed the CDC to create the National Breast and Cervical Cancer Early Detection Program, and that allowed for breast and cervical cancer screening and diagnostic follow-up services for low-income and uninsured women. And so, simple requirements: women ages 21 and older with household income at or less of 2%, 250% of the federal poverty level, who are uninsured, are eligible for free services. And then in 2000, Congress passed the Breast and Cervical Cancer Prevention and Treatment Program, which allowed states to offer women who are diagnosed with cancer through an NBCC EDP program such as ours, the Kentucky Women's Cancer Screening Program, to access care or treatment for their cancer from Medicaid through the Breast and Cervical Cancer Treatment Program. So women who receive their screening and diagnostic services through our program can actually get treatment are actually eligible for treatment through Medicaid. And so this is so important for women to know. And one of the big things that we are constantly working to do is to really promote and really make people aware, promote awareness of our programs. That basically, if a patient of yours or someone you know or you yourself are unable to access breast and cervical cancer screening or family planning, we are here. You do not need to be referred. You can simply go on our website. You can call us directly, because our goal is that all women should be able to have access to family planning and breast and cervical cancer screening without having to pay.
Mm-hmm.
I also wanted to talk briefly about our breast cancer education trust fund, research trust fund. And so that is a program that basically since 1992 has offered community grants in support of local efforts to promote people's information and knowledge about breast cancer awareness. So basically promoting awareness. And so we empower small local not-for-profit locations throughout Kentucky, whether it's a local health department, whether it's another not-for-profit that's not a local health department, to try to promote breast cancer awareness in their community. We're really excited about that, and we have been, for the past couple of years, we've really expanded the number of folks who have applied to our program and who have received grant funding. This is not a R01 NIH style grant program. This is something where if you're a local health department or you're a not-for-profit like a church or the NAACP or somebody like that, if you want to have some funding to promote awareness for breast cancer, apply, and we will get you some money, hopefully up to $30,000 to do the work that you're doing. So, and again, you can go on our website and look at that as well. So in
Thank
going
you,
forward-
Doc.
Thank
No,
you.
go ahead, please.
Nope, that was all I was gonna say.
That
I
was
really
it.
appreciate what.
Well, I was going to say, Dr. Rose, that's a lot of information I didn't even know about. And as you're talking about the cervical and breast cancer and the early detection, you all are saving lives. Just so
Absolutely.
important. Yeah, yeah.
Absolutely. And so we've been really pleased to see that our numbers have been improving. And we've been really working hard to improve our numbers, access to screen, as well as access to screening
Mhm.
over the past several years and really over the past couple of decades. So we feel like we're in a really good place right now in terms of the number of women that we've been able to help, but we're really trying to promote awareness of what we do.
Yeah, thank you. Thank you very much. Dr. White, I want to switch specifically to maternal health in Kentucky. And thank you. You sent me the perinatal and maternal mental health website. Thank you so much. And if you could, I want to ask you, what is the overall status of maternal health? And could you throw in a little bit of mental health with that too, please?
Yes, well, two things that data that we've kind of used to guide us where we need to go. First is we've looked at substance use disorder in pregnancy. When you look at, and people are always asking me about maternal mortality. The maternal mortality rate in Kentucky is, and everybody's got a different number. It's important for people to understand there is maternal related deaths, and that is something like hemorrhage, stroke, heart attack, some kind of direct relationship to that delivery. And then there's pregnancy associated deaths, things that are worsened because the patient happens to be pregnant. The number one cause of maternal death in Kentucky is substance use disorder factor.
Wow. Okay.
So if you look at that number of pregnancy associated, that's a much bigger number than if you're just looking at pregnancy related. So 80% of our deaths have a social determinant of health factor, either substance use disorder, mental health, homicide, car wrecks, those kinds of issues. Our maternal mortality review committee that we have works very hard. At the end of each case, after we review the case, we give a list of these things. If these things had been in place, that person might have died. So we've got a group now, the Kentucky Morbidity and Mortality Task Force, that are taking those recommendations and trying to operationalize them. So there's a group that are just looking at the medical side. And then there's a group of us that I lead that are looking at the social determinants of health side, the nutrition, all of those kinds of things that we know could improve outcomes for women.
Mhm.
So we're looking at this in a very detailed way now, and we're very pleased at what we're able to tease out, because now we know where to focus. Now we know where to go and what kinds of things to do. We looked at Medicaid data for the number one reason to be readmitted to the hospital in the first 3 months after giving birth for Medicaid patients. And then in 2020, the number one reason was suicidal ideation.
Wow.
Yeah, that's what my eyebrows did when I read that.
I know. Yeah.
So the women are telling us we need this. So this
Mhm.
is a postpartum issue. So how
Mhm.
can we reach out to women? So Dr. Rose's group allowed us to use their resource website. We have a group of perinatal mood disorder specialists that we have pulled together, academic, clinical practice, people with patients with lived experience, and we've come up with a list of resources, and that's what I sent you today. And I think Heather's going to send out after this call, where we've got resources for providers as well as for patients. Because back when I was in medical school, we were certainly not trained on what to do. If Lucy came into my office postpartum and I knew something was wrong with her, I did not know what to do. And I didn't know how to refer her to the right person. So we've got lots of resources now that we are pulling together to make that a much smoother transition. We will be starting in October a group called Kentucky Compass, which stands for for public health. Everything stands for something clever. It stands for the Consultation and Outreach for Maternal Psychiatry and Support Services. Right now, if you go on that resource site that we're talking about, there's a big green box. It's a 1-800 number. And if you're a patient and you think you have a mental health issue and you just want to talk to somebody, you can call that number. This consultation line we're building is for providers. So like I said, you come in my office, I have no idea how to help you. I can call this number and I'm going to have a perinatal psychiatrist or a specialist in perinatal mental health to advise me how to best take care of you. And we're going to have an outreach person that will reach out to you with your permission to help you know, are there any postpartum support groups in your community? Is there a Facebook page? Is there a provider that you could go see? So it's a way to try to help the provider better help the patient. So we're trying to really target in on the things that the data is telling us are our problems. I'm very pleased. Our last maternal mortality review showed that when we looked at data in 2021, our rate of death of Black and white patients was the same. I don't think there's any state where that happens. Many states, it's 2 to 5 times higher in Black Kentuckians. Will that be the same next year? I don't know. We're still looking through that data, but what data we have is very encouraging. We know that rural women have problems more than urban women because we have something called maternity deserts. I believe it's 40% of our counties in Kentucky don't have a birthing hospital or an obstetrical provider. So women have to drive long distances for care and for delivery. So we just got a grant from the National Association of State Health Policy that's going to help us we've got some innovative ideas of how we can help these women in the counties that are maternal deserts. How can we connect them to community health workers or doulas or peer support specialists who can get these people? Again, we want to utilize the resources we have. How can we get them connected to our hands workers and our food banks and transportation and all the things that are out there that are available? But the patient has no idea knowing that that's even available to them. I'll stop there. It goes on, but I'll stop.
It goes on, yes. We like a couple hours. I know.
Yeah.
Okay, so this is a question for either one of you ladies, and you've both touched on it. Improvement in women's health, like the cervical breast screenings, maternal mortality rates. So what other areas have you seen where women's health has improved in Kentucky over the past couple of years?
I think for me, one of the biggest one is decrease in our smoking rates. When I started in 2009, we had one county in Kentucky where 50% of the pregnant women in that county smoked.
Oh, wow.
Yeah. So we've gone down markedly in Kentucky. I mean, statewide, we're down to about 11%. But nationwide, that rate is about 3%. But we're getting there. We don't have statewide smoke-free laws, but we do have all the medications that are available for smoking cessation are paid for by MCOs. We have a tobacco quit line in Kentucky. And if you let them know you're pregnant when you call, you'll get the same counselor every time. You can do this by phone. You can do this by email. You can do this by text. And if you're pregnant, you get more postpartum calls as part of the package that you get. And you actually get paid. We have money that we are giving you a stipend. If you're pregnant and you connect with the quit line, you get some reimbursement for that. So we're very excited about that. If we can just get providers and the public to know that that's out there. Anything we can do to help this person, because so many medical issues and maternity issues are connected with smoking. Tobacco kills 500,000 people every year. 500,000 people die, and it's not just lung cancer or COPD, it's heart disease, it's diabetes, it's all the things that go hand in hand with tobacco use. So if we can get people to change their outlook on that, and like I said, our numbers have gone down substantially, the more we can get that number down, the better our health outcomes are going to be. So I'm proud of that drop. I wish it
Yeah.
was lower, but I'm
Yeah.
proud of that.
Yeah. Thank you. Dr. Rose, what have there been any women's health that has declined, that has worsened over the past recent years? What are those?
Was actually going to talk about an improvement for a minute, and I was going to say
Yes, please.
and one
Yes.
thing that I am excited about is the fact that cervical cancer screening has increased among Medicaid enrollees, and so that I think is a win for us. And of course, just what we talked about before with the Medicaid expansion. In terms of worsening areas, obviously, I defer to Dr. White and her knowledge for in terms of maternal issues, but I would say from the perspective of obesity and diabetes, unfortunately,
Okay.
just like the rest of the world, obesity and diabetes is continuing to increase, which are risk factors for chronic conditions, and certainly can play a role in maternal and pregnancy complications as well. We have one of the highest obesity rates in the nation, and we have a higher than national average rate of diabetes as well. The other things I'll leave to Dr. White, talking about maternal health as well as mental health and substance use.
And I do want to touch on heart disease. Dr. Rose,
Yeah.
so heart disease in women, specifically in Kentucky.
So this is actually really important. And I think one of the things that we need to make people aware of, and of course, your original question was, heart disease is the #1 cause of death for women in Kentucky. What can we do to help raise awareness of this? And I think that's one of the most important things we need to raise awareness of. One, that heart disease is the #1 killer. Two, that it looks different in women. And we need to continue to do our research. We need to make people aware that women display different symptoms. And it's not that their symptoms are, it's simply because the research was done in men, right? So the research was done in men. So what we think of as the typical heart attack symptoms, jaw pain, down your left arm, crushing substernal chest pain, et cetera, those are men type symptoms. So first of all, we need to know it's the #1 killer and it looks different in women. Then we need to know that things like women don't always get the right diagnosis because it looks different. Oftentimes women don't have the typical male symptoms. Also, women may visit their doctors later than men do when they have coronary artery disease symptoms, and they may have fewer diagnostic procedures performed on them. Also, women, when they present and when they actually get diagnosed, such as with a cardiac catheterization, which is sort of standard of care, they may have clean coronary arteries because they may have a different type of coronary artery disease, which is known as microvascular coronary artery disease. More prevalent in women and can lead to serious cardiac events, just like the macrovascular coronary artery disease. I want to talk a little bit too about how cardiovascular disease and heart disease in general can look different in different stages of women. So you think about different stages in your life and how that might look different, and the things that you may be doing during those different stages of your life and how that may increase your risk. So let's think, for example, about our 20s in general. So we might be taking birth control. We might be smoking. Both of those things can increase our cardiovascular comorbidities. They can increase our risk if we already have a genetic propensity to blood clots, for example. Those things can increase our propensity, and of course, having a blood clot can cause pulmonary and heart conditions or exacerbate those types of things. Then you get into your 30s and of course, maybe in your 20s too, but you're thinking about getting pregnant. Maybe you're taking fertility drugs. Both of those things, pregnancy as well as fertility drugs, can increase your risk of cardiovascular complications. Then let's get into our 40s and 50s. We're starting to maybe go through perimenopause and menopause. We also are developing high blood pressure, high cholesterol, or we may have already been developing it, but it's starting to actually present itself. And so all of these things obviously can put women at risk for an MI. And menopause itself. So let's think about as we're in our 50s and 60s and beyond, as we're going through menopause and in postmenopausal period. So we have that reduced estrogen, which can increase our risk of heart attack and stroke, increased risk of peripheral vascular disease. So those are really important things to be aware of. Like I said, women present differently. More likely, that's the number one cause of death in women, and we need to think about those specific timeframes in which we may have different risks.
Thank you, Dr. Rose. Let me throw this question, because you said it's unrecognizable, not as recognized as it is in men. Different symptoms. Do you think, in the mental health field, mental illness or panic attack or palpitations, or could that be dismissed sometimes, when maybe it's really a heart problem, but
Absolutely.
it's
Absolutely.
this,
We've all
you know,
seen it where women go in and they're told they're just
Yeah.
stressed, they're just
Yeah.
anxious, or they're just having a panic attack. So, our goal as physicians is to always make sure that we take people at face value. So if you're coming in with palpitations, you're coming in with chest pressure, we should be doing an EKG, we should be doing an echo, or whatever kind of evaluation is appropriate. Obviously, I don't want to speak for physicians, but I would say that mental health, I personally believe that your mental health is just as important as your physical health, but I would consider that to be a diagnosis of exclusion, right? You want to exclude all the scary stuff that's going to kill you, which obviously mental health can kill you, but you want to exclude all the physiological stuff that can kill you before we start thinking, okay, maybe this is anxiety. And of course, that's important as well.
Rule
but
that out. Yes.
yeah, absolutely.
Okay, thank you. Dr. White, do you have anything to add to that?
No,
Okay.
other than making sure people are taking their meds and being compliant because they can't afford them. And we have programs here that can help people get medications that the drug companies can pay for. So
Right.
that's another. I'm looking at Heather. We're giving her all kinds of ideas of future
Yeah.
things the commission to
Yeah.
do. Two things I do want to mention, and I will do it quickly because this is a plus. We have greatly increased the number of inpatient treatment for women with substance use disorder that are pregnant or have children and can bring their children to those residential.
That's wonderful.
And that
Yeah.
doesn't happen in a lot of states. We
It
also
does.
have the HANDS program, and I don't know if you've heard of HANDS.
Yes.
Health Access Nurturing Development Services. I have to read it because I just don't ever say that. I just say HANDS. But we know that our HANDS families have less preterm birth, less low weight birth, less smoking, and less referrals to Child Protective Services. Every health department in every county, all 120, offer HANDS, and there is no financial limitation. Anyone can become a HANDS family. So we strongly encourage, whether you're a first-time parent or you've had other children. HANDS is something that we have that is really, don't tell the other programs I said this, but it is the gem of our public health. We're not supposed to have favorite children, but HANDS has been around for a lot of years and has reached a lot of families and saved a lot of lives.
Absolutely. They're a wonderful program. I've been involved with them before, worked with them, just collaborating. And I feel like they really wipe away some barriers for women. And just like you said, the facilities where the women can take their children with them if they're going, for a substance use disorder. Because what I see in my field, a lot of times women aren't going. They're not going to leave their children. There's barriers. They got to be home. They're, taking care of their husbands. They're cooking meals every night. And they sacrifice themselves and they don't get just too many barriers. So I was glad to hear you say that about.
And then they end up in Dr. Rose's office with heart disease.
Exactly. There you go. Yes. Another question for both of you, and we've touched on a little bit of it. But what are some other lesser known women's health issues that are prevalent in Kentucky that we need to know about? We need to be aware. What would
One of-
those?
One of
Yeah.
my favorite ones that we all need to get our homes checked for radon. Radon is the number one cause
Yeah.
of lung cancer after smoking. It's a
Mhm.
simple thing to do. You can get it at your health department. You can buy it at Lowe's. The health departments don't have the grant anymore to give them away.
Mhm.
They know where you can find them. If
Mhm.
you have radon in your home, it's dangerous, and everybody should be testing their homes for that. So lung cancer is big. I'll pass it on off to Dr. Rose.
Very good point.
So one thing I want to mention is disordered eating and mental health. So disordered eating, so we're not only talking about anorexia and bulimia, but also binge eating, stress eating, nighttime eating, boredom eating, emotional eating. All of those things can fall under that. And there's a lot of stuff I could talk about, but what is interesting about disordered eating is that it's actually positively correlated with weight. So in other words, the heavier you are, the more likely you are to have some sort of disordered eating. And so we often might think of a woman with, or a person with disordered eating as a very thin, somewhat privileged woman. But actually, it's more often seen in women of higher weight. The other thing is binge eating disorder specifically is actually the number one disordered eating disorder. I shouldn't say eating disorder, type of disordered eating in Black women. And so that's important to recognize too, because I do think that women of color are underrepresented in terms of recognizing mental health issues, recognizing disordered eating specifically. In terms of other things, there's a lot of other things we could talk about: sleep health, dental health and pregnancy, autoimmune disorders, and of course, menopause. I think that's something that is just really becoming something so important that we're learning so much about. I know as a physician, I'm learning so much about menopause in terms of treating my patients. So I think that is something that we're going to continue to grow and hopefully learn a lot more about.
Yes, thank you, Dr. Rose. We have time for a few more questions, and we will check. I think Heather is checking the Q&A. Another topic I'm interested in and how it could affect women is pre-K 4. I want to touch on that a little bit. Again, we've talked about women, moms, barriers, they're the caretaker. But what potentially could that do for females in Kentucky and women? Can we talk about that for just a little bit?
Well, if you go back and listen to the last one of these talks that I listened to, which was fascinating with the Kentucky stats people, I mean, women get paid less than men do. And women don't go and get advanced. Well, I guess women do get more advanced degrees than men, but when you look at income, women are making less money. And part of that is because they're doing the very same job. Eleanor Jordan, we spoke about her. Her mother was a housekeeper in an apartment complex, and there was another apartment complex next door that the guy there that did the same job she did was a janitor, and he got paid more than she did. Although they did the same work, they had different names, and she got paid less. If we can start at a very young age, and that's a whole other one, Heather, adverse childhood experience and positive childhood experiences. If we can get our littlest Kentuckians to learn to have that self-respect for each other and to elevate each other, as they turn into adults, we're going to have less of those disparities of attitude. Because when you have those attitude disparities, that changes everybody's trajectory. So if we can get kids at a very early age into a setting where they can learn this, they can learn self-regulation. I think we would see it. Well, I know we would see, studies have shown, we would see a tremendous difference in the teens and the adults that we produce in Kentucky. So when I heard this yesterday, on the governor's update about this pre-K for 4-year-olds, it's exciting, and it has a huge impact in what's going to happen to my Kentucky as I grow older.
Yes, absolutely. Dr. Rose, do you have anything to add to that?
Tell them, Stephanie, be sure and tell them to buy those pink license plates so your foundation will have money to give away.
Yes, Breast Cancer Trust Fund. So I'm sorry I don't have a lot to offer to the pre-K 4, although I love hearing Dr. White just talk about everything.
Yeah.
So Breast Cancer Trust Fund, the one thing I didn't mention about the Breast Cancer Trust Fund is that it is actually funded by the state of Kentucky, by the citizens of Kentucky. So it is funded through either the breast cancer license plates that you purchase when you get your license plate, or it is funded through tax donations. So when you finish your taxes at the end of in April 15th, you check that box and give us some money. And that allows us to provide access to funding and grants for communities all across Kentucky.
Wonderful. Let me ask you this too. It's not a part of our questions, but I'm curious, what is the recommended age for your first mammogram?
That's an interesting question.
I've heard different, yes.
So it depends on what guideline you use.
Okay.
So and as you may know, several years ago, there was a big uproar in terms of the guidelines, in terms of whether or not we needed to start at 50 as opposed to 40, where we had been starting for a long time. And part of the reason for that was there was a big study done, and the study started at age 50. And part of the reason it started at age 50 was because the study was partly started in the UK, where mammogram or breast cancer screening is started at age 50. And so and then the study did show that there can still be some debate about that 40 to 50 age range. So there are still folks who do recommend starting at age 40. There are still many folks, as a matter of fact, and some societies, some different task forces or different sort of societies that determine how we should be screening. But then there are others that recommend starting at 50. There are some that recommend annually. There are some that recommend every other year. And so it can be challenging. Now, obviously, we're talking only about women who are at average risk. We're not talking about women who have any increased risk of any type. And some of the nice things that have been done, or one of the nice things, is that we have many more tools to look for those increased risks. We have risk scores, risk calculators as well. So not only is a woman just going in to get a mammogram, but we're also determining whether or not it might be at increased risk based on family history, personal history, dense breasts, etc., and whether or not we need to utilize other tools. So essentially what I did was I didn't give you a direct answer.
But thank you for explaining. Yes.
But in general, it depends. And I would say that you're probably going to get it. The general answer is definitely ages, starting at age 50. But a lot of people still do start at age 40 for those average risk women, and there's nothing wrong with that.
Thank you.
And
thanks for
a new
explaining that.
recommendation that's important for Kentucky. We also do colon cancer screening here at the Department of Health. 45 is the new age that you should start getting your annual screening colonoscopies. We are seeing much earlier colon cancers in Kentucky. In fact, in the United States, and Kentucky has one of the highest rates of younger people getting colon cancer. So if you're having rectal bleeding or changes in bowel habits, go to your provider and get that conversation. But even if you're just an average risk person, like Dr. Rose was talking about, 45, start getting those colonoscopies.
Thank you. Yeah, thank you for sharing that.
Just to go back to the mammograms for a minute, like I said, there's those different screening guidelines. And so some are very strong about starting at age 40, and some are not as strong. So something to think about and talk to your doctor about.
Thank you. Thank you. Heather, do we have any questions in the Q&A?
We do not.
Okay.
You've covered everything.
I think we've covered everything. I know.
Right.
I'd love to ask more questions. Yeah.
I'm sure we've actually only scratched the surface.
Exactly. Yes. Yes. I want to learn more. Dr. White, thank you, because we had not brought up colon cancer. So thank you for bringing that up and talking about that. And I did not know the stats on that either. So I appreciate that.
Right.
Heather, I will turn it over to you. Let me thank Dr. Rose and Dr. White. Thank you so much for being here, sharing your time and your information. We really appreciate it, and I know the audience does too. Heather, I'll
Thank
give it
you.
back to you.
Thank you, Lucy. What a great session. I knew it would be because of the amount of knowledge that you, Dr. White and Dr. Rose have. It's just incredible. And we're so lucky to have you as not only part of the Commonwealth, but part of, state government. It's so wonderful to have experts, and I learn something every time I talk to you all. We are looking forward to working with the department on a future information sharing collaboration on women's health. And so hopefully we can all stay tuned for what that might look like. But thank you all for taking time to join us and be here with us today. I also want to thank the commissioners who were able to join us on the call and remind all of our audience that this will be archived on our YouTube channel for future viewing and reference. Our next Conversations with Commissioners is scheduled for August, and our topic and guests will be announced soon through our social media channels. If you're interested in keeping up with the Kentucky Commission on Women, our future meetings, our future events and programs, you can sign up through our Contact Us page on our website, which is women.ky.gov. You can follow us on Instagram or Facebook, or you can subscribe to our YouTube channel and get notified when we go live with any broadcasts. Thank you again. We really appreciate it, and we will see you again soon.
Thank you, ladies.